Hello everyone, in this video we describe a very unusual complication of a nucleus drop that occurred due to a viscoelastic cannula and its management using a glued IOL. So this case, as soon as the viscoelastic was introduced, the nucleus drop occurred because of the impact of the cannula, probably because the viscoelastic was either stuck in the cannula and the cannula was loosely fit on the syringe. This was a novice assistant, and even though these things are drilled into all the assistants and all the residents, but sometimes these unusual things do occur, as you can see again here, that as soon as the viscoelastic is being introduced, the nucleus drop occurred. So then the retinal surgeon came over and managed, this is a scleral tunnel being made in anticipation of a scleral glued IOL that will be used. And then after making the scleral tunnel and preparing it for the glued IOL, the trocar is used for making scleral ports. So 3 scleral ports have been made. And then we do the standard procedure to remove the nucleus. This is the vitrectomy that is being done to clear all the vitreous around the dropped nucleus. And then now, once we have isolated the nucleus, a little bit of triamcinolone is injected around the nucleus to free it completely and remove any further vitreous that may be stuck onto the nucleus. And then again, vitrectomy is done to thoroughly clean. So now the nucleus is completely free, and a phacofragmentome in the DORC-EVA vitreoretinal system is being used to eat up the nucleus. And now, as you can see, the retina is completely clear, so is the vitreous, and the nucleus has been very completely and cleanly removed. This is the Sensar 3-piece IOL that is being injected, and the max grip forceps is being used to externalize the haptics using the handshake technique through the tunnel that was made prior to inserting the IOL. And the second haptic is now again being externalized in the opposite tunnel using again the handshake technique with the max grip forceps. So once both the haptics are externalized, the haptics are inserted into the tunnel that was made for this purpose. And this is the haptic that is being inserted and fixed into the tunnel so that it stays there. And the tiny scleral flaps over the tunnel are now being sutured to provide stability to the haptics and to ensure that the IOL stays in position. Now, the main issue is to fixate the IOL in such a way that it remains stable. Incisions are sutured, and then a bandage contact lens is placed to avoid any irritation. So the take-home message is that even now, even though everyone knows the importance of cannula being fixed properly onto the syringe, we have to be very careful. Make sure that we use locked syringes, which will probably avoid this complication, and check this again and again in every case at each step. Thank you.